Hello there, this is John speaking, and this is Geriatrics Chapter 39. First and foremost, the number one things you have to consider when you're treating or assessing any type of geriatric patient is you really need to develop and their trust in you and why you're there. Communication is really, really important. They can be very evasive when answering questions because they have these issues with fear of going to the hospital, fear of strangers. Um, I know a number of geriatric patients have told me they're just scared of everything. So if you can prove to them, you know, that you're here for them and your number one goal is to get them where they need to go safely and into the right hands, it really allows them to kind of open up to you and tell you exactly what's going on. So you'll have that information to be able to understand what's going on and also maybe take them to the right place they need to go. They have different physical responses to illness and injuries, and this is because of the aging process. We've talked about this before. We know the heart changes, the liver, the kidneys, all the major organs change. And we have to factor this in when we're assessing a geriatric patient. We have to rethink the way your assessment parameters are. For instance, someone who's 20 years old and their blood pressure is 120 over 80 and their heart rate 70 strong and regular and their breathing's 18 times full and effective, that's normal for them, but it's not normal for someone who's 90 years old or 80 years old. So if you look at what's normal for someone who's elderly and how they're presenting today, if you see a geriatric patient with a blood pressure of 110 over 70, they actually might be in shock, but because you're using the assessment parameters, based on the common average healthy person, you miss the fact that they're actually going into shock. So you need to completely rethink the way you look at this patient and rethink what's normal and what's abnormal. On top of all that, you have what's called comorbid factors. These are the medications they take. These are the diseases that they chronically deal with every single day, and they take lots and lots and lots of medications. Polypharmacy is pretty much the rule. That's usually like 5 or 6 more or more medications at a time. And I'm sure you'll see them out in the ER. You'll see them when you're doing your clinicals. They have whole bags of medications, whole shoe boxes full of medications. That's polypharmacy. So you can see they have all these medications, these blood thinners, these beta blockers, and all this interaction and all these chronic diseases. So they have all these problems, and we need to look at this thing as a whole. Their social issues, their physical issues, their emotional responses to us being there, and their illness, and what are they taking? Why are they taking it? And is what they're taking actually the reason why we're here today? We get called out a lot for social services. Number one is failure to thrive. This is a patient who is usually elderly, but they can also be, disabled in some way, have some type of organic brain syndrome going on, and they're just not able to take care of themselves. They can't get to the bathroom to use the bathroom. They can't get to the kitchen to feed themselves. They live by themselves. Usually, the house is just completely crazily filled up with dirt and dead cats and all kinds of lovely things. Maybe someone comes by to say hi and they see this terrible conditions. They call, and this person needs to be, even against their will, they put on a hold, and they get taken to the hospital against their will to be, obviously to be rehydrated and renourished, and then they're sent to some type of facility where they could be cared for by other people. Suicidal ideations are not that uncommon in the elderly, especially if they have some really bad chronic illness, and it's very, very painful, and it's affecting their life and their quality of life. Also, it's been shown that if you have a husband and wife, or you have partners, and one of the partners dies, the other partner dies within 1 year of the partner passing on. Now, this could be from natural causes, or could be from committing suicide, but it's pretty common out there. So they get really depressed because their husband or wife of 50 or 60 years is no longer with them. And then again, that leads to the isolation issues. They're lonely. All their families moved out. Their friends have all died off, and they're left alone. And they have almost like this survivor guilt going on. And there's no one to talk to. And they usually, they'll call 911 just so they can have somebody come by and like, visit them. If you might, if you go out there, you might see elder abuse, negligence, elder abuse. I've seen sexual abuse of the elderly. Was primarily with someone who has Alzheimer's or dementia. Neglect would be not giving them their medications, not feeding them, not caring for them. And of course, like I said, that with the polypharmacy, they could either on purpose or by mistake take too much of their medications, which would lead to an overdose. So the various effects on the body systems, we talked about this a bit already. When it comes to the skin, the upper picture right there, those are skin tears. They're very, very common in the elderly. The skin is super thin. It's parchment thin, kind of stiff. It easily tears. That's why I've been mentioning to you guys, when you are loading them on the gurney, or you're putting straps on them, or you're putting on some kind of bandaging, you want to make sure that bandaging is moist so it doesn't stick to the skin, because you pull the bandaging off, it'll take the whole skin, with it anyway. Or the straps on the gurney rubbing against the skin can cause skin tears. Remember too that because the skin is so thin and now is ineffective, it doesn't allow them to control their body temperature as well as a younger, healthier person. You might have noticed, you go to your grandma's house, she's got 4 sweaters on and the heater going. You can kind of see why. They just can't, control their body temperature the way a younger person can. You've already learned about the cardiovascular system, people having silent heart attacks, which means they're not having any chest discomfort. They're not having the typical radiates to the left arm and 8 out of 10 scale, substernal, all that stuff you learned about. This is more the patient is, I don't feel good today. I feel like I've got the flu. I have this funny ache in my stomach. I have this funny ache in my jaw. Those are all very, very vague complaints. They could all be heart attacks. Remember too that as you age, you get hypertension developing for various reasons. So you have hardening of the arteries, and you also have the plaque development from all that hamburgers and French fries we've eaten. And so between the two of those, you start getting increased diastolic pressures. So your diastolic goes up, which then again will turn into your systolic going up as well. So they become chronically hypertensive. I mean, 160/90 is probably a fairly normal blood pressure for someone in their 70s and 80s. The only reason why we don't see it so much is because they're usually on some type of hypertension medication to drop down that blood pressure. When it comes to the respiratory system, maybe they were smokers, maybe they have COPD, maybe they have emphysema or chronic bronchitis. There is an increased chance of infection because they've damaged the cilia, the little tiny hairs in the respiratory tract that helps us cough out that gunk that we normally breathe in every day. So they retain the bacteria, they retain the viruses. So a lot of times they'll be calling us because they just have some kind of breathing problem and it's related to pneumonia or some kind of bronchial infection going on. Neurologically, the brain shrinks physically in size, and this is a big concern for us because if you have this fixed cranial vault, the skull itself is a fixed size, and the brain shrinks, there's more movement inside there. So if this elderly person falls and strikes their head and the brain shifts around, the brain itself can tear, the blood vessels can tear. There's a much greater chance of bruising to the brain or some type of intracranial hemorrhaging going on. So anytime an elderly person falls, we're really concerned about them having some kind of brain injury. They need to go to a trauma center and have a scan done. especially if they're on blood thinners, because that even makes them more prone to this process. And the rest of it is just, more of a sensory thing. So loss of taste and appetite. I've heard it from a number of old people basically saying, I'm tired of eating. I have no appetite whatsoever. Food doesn't taste good to me anymore. And this leads, of course, to malnutrition and dehydration as well. Their vision can change, and obviously you've heard of cataracts and glaucoma. And of course, they may or may not get the surgeries. They may not wear the glasses. So again, they have problems. They trip over things so they can't see things like that. And another condition that they get is called neuropathy, and this is a condition of the nerves. It starts usually in the feet. It can also be in the hands as well, and it's a combination of a sensation of kind of an uncomfortable tingling sensation, a numbness, and also sharp pains, all kind of at the same time. And it's very uncomfortable. And sometimes it makes them difficult to walk because it hurts so much to walk sometimes from this. They do take medications for this. I think Neurontin is one of the medications that they are pretty commonly prescribed for when this, but it doesn't always help, and it's very uncomfortable. There's two terms, dementia and delirium. So dementia is a permanent medical condition caused by usually plaque or damage to the brain cells, and it's a permanent condition that gradually gets worse over time. Alzheimer's is a subset of the category of dementia. It's part of the dementia process, and it's irreversible, in both cases. Now, delirium is actually something that is reversible. For instance, if someone has a really high fever, like 105 degrees, massive bacterial infection, they're going to be out of it. They're going to be delirious. They're going to be, acting strange. But once the fever's over with, once the infection has been taken care of by the hospital, they regain their normal mental status. So people can become delirious, but they can recover from it. With dementia, they can't. And again, Alzheimer's is that subset. Alzheimer's is the one everybody hears about, talks about. They do go through stages. And my only thing I have to say about this is there is sometimes a stage of Alzheimer's that makes them very violent, very aggressive towards people. They'll hit you, they'll attack you, they'll try to claw you. So just be aware that you might meet up with that person who's in that stage. It's not their fault. Obviously, it's the disease process, and they will pass through that at some point. The gastrointestinal system. So number one thing, of course, is you get the gut motility, the movement of food down your esophagus, into your stomach, and through your small and large intestine slows down. And so consequently, they're more prone to constipation, and then impaction, which is actually fairly life-threatening, because if they do have an impacted bowel and that bowel ruptures and that stool pours out or comes out into the abdominal cavity, it can lead to peritonitis, sepsis, and death. So ultimately that's a really bad scenario. But of course, again, I talked about they don't eat because it doesn't taste good anymore. And of course, the liver decreases in size, and this is a problem for a number of reasons, because think of all the medications they take. Some of the medications are lipid solubles, so they're filtered through the liver. And because the liver is no longer functioning as well, they're less able to filter those medications. Now, the endocrine system, of course, is our hormones. And hormones change. Some increase, some decrease. You've all heard about, a female who's postmenopausal, so they're no longer producing the reproductive hormones. But some of their hormones actually increase, as do male hormones as well. And these indirectly lead to increased blood pressure as well, along with the other things we talked about earlier. And insulin, of course, is a hormone, but the body becomes less responsive to the hormone or insulin, the cells themselves, which leads to this increased blood sugar levels, which eventually possibly leads to type 2 diabetes, hyperglycemia, and that hyperosmolar non-ketonic syndrome we talked about that leads, unfortunately, to pretty bad dehydration, which is already a problem in this age category. Musculoskeletal systems. You can see this the skeleton right here. There's quite a bit of kyphosis, that kind of humped back right there. You can see the distance from the back of basically the occipital part of the skull to the spine. There's about 8 inches or 10 inches of difference. If you put this person on a spine board, you'd have to have about 8 or 10 inches of padding to make up that void. Not an uncommon, call you're going to get. So obviously, with the aging process, you do get osteoporosis. The people who are postmenopausal, seen more in females than males, but males also experience this to some degree. Makes them more prone to fracturing bones. If you're on your skateboard or your electric bicycle or your whatever it might be, and you're 25 years old and you fall off your bicycle, you're going to get back up and get back on the bicycle and keep going. That same exact fall that you take and get up and leave, it fractures this person's bones. They're so fragile, they're so light. Unfortunately, the density of the bones are so light. And again, there's that kyphosis again, that humpback kind of situation that you have to compensate for when you're putting them in spinal motion restriction. Kidneys become smaller. I mean, just like we talked about the liver, the kidneys are less effective. They filter ions less effectively. They control the patient's fluid levels less effectively, can make them more dehydrated. Again, you're falling back on the whole process. They drink probably lots less liquids than they probably should. The number one sign of dehydration in the elderly population is poor oral hydration, which means a dry tongue and a dry mouth is a sure sign that this old person is dehydrated. And lastly, we spoke about this already a little bit, but they can become toxic for their drugs. Remember, they have this polypharmacy thing going on, and with the decreased liver function and the decreased kidney function and the dehydration and all the other things going on here, if they're taking their medications and these medications build up, they can't eliminate them as they normally would through their stool or through their urine, and they just build up to a toxic level, which might be the reason why you're getting called out today. And that's why it's so important to know what drugs are they taking, any new drugs they started on recently or medications they started on recently that might be interacting with other medications they're taking, or just something, it's a side effect. So it's really important you understand what they're taking, why they're taking them, and what's changed in their dosage, what's changed in what they've been taking. So we're done.